Hello, everyone. It's almost good afternoon. I thought I'd be saying good morning. Right, so I'm Professor Padidela. I'm one of the pediatric endocrinologists and metabolic bone disease consultant at Royal Manchester Children's Hospital. I'll be discussing about bone health, pubertal delay, and also how to manage intercurrent illness from the endocrine point of view. Nothing to disclose regarding my talk today. And it will be mainly about puberty, bone health, and how to manage illness with extra doses of steroids. Okay, so what exactly is puberty? For me, this is what it is with my teenage kids, or this. But as an endocrinologist, it is this. It is all about the increase in the size of the testes. So I do have patients coming in, family coming in. We've got hairs down below. We've got hairs under the armpit. Is that puberty? No, it's not. I need to assess. I need to check what the size of testes is. So for boys, the onset of puberty for us is when there is an increase in the size of the testes. If they are in the blue zone, as they are here, they are not in puberty. If they are in the yellow zone, they are in puberty, they have started puberty. And based on the stage of puberty, the size of testes increases. And it reaches the maximum size when we reach the end, when the boys reach end of the puberty. Now, how does puberty start? It all kickstarts from the brain, from the hormones known as LH and FSH. And what it does is that increases the size of the testes. And once the size of the testes increases, it produces testosterone. And when the testosterone, this male hormone, is produced, it tells the brain, yeah, that's fine. Let's kickstart and let's speed it up so that we can finish puberty. So the testosterone production is important. And once the testosterone production is happening, it is a chain reaction then. So what's the age for onset of puberty? It's from 9 to 14 years of age, but average age is 12. So around 50% of boys will start going into puberty by 12, but most will finish puberty by 14 years of age. And we very rarely see boys going into puberty earlier than 9 years of age. And this is what happens with puberty. The size of the testes increases. When they're not in puberty, it's less than 4 milliliters. We've got beads which we can use to measure. And when they progress through puberty, the size of the testes increases. When the size of the testes increases, there is increased secretion of testosterone, and then it brings about all the other characteristics which is seen in boys when they progress through puberty and become men. The peak height velocity tends to be at a later stage of puberty, but it can be suppressed because of the ongoing steroid treatment. When do we say it's delayed? It's delayed if puberty hasn't happened by 14 years of age. And it's not uncommon. And why puberty is important? And it's important because it causes sexual maturation and development of secondary sexual characteristic. There's an increase in growth. We call it as growth spurt. There's increase in muscle and bone mass, and it's important because the bone health is already compromised because of the steroid treatment and low low functioning of the muscle. It does increase mood, confidence, and self-imaging, and it allows abstract thinking. That's the difference between boys and men. It allows boys to become men. Now, delayed puberty in Duchenne's muscular dystrophy, almost all patients on steroid have delayed puberty. And it's important to recognize that almost all patients with Duchenne's muscular dystrophy receiving steroids will have delayed puberty. And this is the consensus guidance from 2018. And there was this advice to start assessing puberty from 9 years of age. I tend to do a bit later because the treatment usually is by around 12 years of age. But yes, it's good to start thinking about it from 9 years of age, at least assessing puberty once a year. Delayed puberty, as I mentioned, if the volume of the testes is less than 4 milliliters, then you're thinking of delayed puberty by 14 years of age. refer to endocrinologists, but most of them are under me because of monitoring bone health, so they're already under me. There is advice on measuring these investigations. We could do it if there is a blood sampling done, but generally I don't need to do this because the most important thing is examining to see what the size of testes is. If it's less than 4 milliliters, I know that all these hormones will be low because there is no onset of puberty. And recommendation of treatment to kickstart puberty is definitely by 14. But if we know that most boys are going to have delayed puberty, why not start at 12 years of age? Now, how do we kickstart puberty? So we could give testosterone replacement therapy. And as I mentioned in the past, in my previous slides, that it's the testosterone which is secreted by the testes then creates the chain reaction, and this is where we are acting now rather than acting here. So once we give testosterone, it then starts the chain. Naturally, the whole process starts from brain secreting LH and FSH, then testosterone, and then the chain reaction starts. But what we could do is that we can give testosterone and then start the chain reaction. It's usually given as intramuscular injection every 4 weeks. There are also testosterone gels we can use. The problem is that the compliance can be variable. If injection is given, it's given, we know it's gone in. And also if there is testosterone gel used, then the clothes have to be washed separately. Whoever is applying needs to wear gloves to apply it because the testosterone can go in the individual who is applying it. So there are 2 ways of giving testosterone. The first one is a short course treatment where we give small doses and increase it. We assess every 4 to 6 months to see if there is increase in the size of the testicular volume. And our target is to reach around 6 to 8 milliliters because then I know that the testes will be able to produce enough testosterone to maintain the chain reaction to complete pubertal development. So the aim is to reach 6 to 8 milliliters. Sometimes it takes 1 course, sometimes it takes 2 courses, sometimes it takes 3 courses of testosterone injection. When I mean course, each course is around 4 to 6 months. Again, as I mentioned, it is small incremental dose. And what this testosterone does is that it increases the size of the testes. And once it reaches 6 to 8 millimeters, I say, well, fine, you should be able to go through puberty now. There is another way of managing it, and this is a long-course testosterone replacement therapy. This was investigated by the Newcastle team, where what they did was they took all the boys from the very beginning to the end of the puberty giving testosterone injection. I have very limited experience about this. Now, when we give testosterone, we got to have a balance. If we don't have the balance, we can actually cause harm than benefit. The balance is a short course to stimulate puberty, but the long course can suppress it because if you give too much testosterone, the brain then stops producing the hormones which increases the size of the testes. And therefore, that balance has to be there. And therefore, we are a bit cautious in giving very high doses and for very long duration of time because it can also suppress it. So that balance needs to be maintained. Moving on to bone health now. Again, long-term use of steroid because of reduced muscle function, because of reduced muscle activity, because of delayed puberty, there is compromise on bone health. Nutrition and vitamin D deficiency can also cause it, but almost all of my patients have vitamin D supplementation, so that's not an issue. None of them are nutritionally compromised, and I do emphasize that they have a diet rich in calcium, taking milk, cheese, and yogurt, so that's not a problem. So it's mainly the top 4 which causes effect on bone health. What does osteoporosis and Duchenne's muscular dystrophy cause? It causes long bone fracture, and it's very unfortunate that once the long bone fracture occurs, mobility is, in most children, reduced, and they become wheelchair bound. It can also cause fat embolism, so it's important for us to be able to prevent this from happening. And it can cause backbone fractures, known as vertebral fractures, which can be silent to begin with, but can present with back pain. It can cause low mood and reduced quality of life. So how do we monitor? We start doing bone density scan from 5.5 years of age. They are referred to us at 5 years of age. We always look at the spine views during bone density scan, just because we don't want to miss those silent vertebral fractures which can occur. And this is how the bone density scan is performed. That's patient lying down on a couch there, and this is the bone density scanner. It takes around 3 to 4 minutes, and very low radiation, negligible radiation at all. And we have started looking at the spine in the vertebrae because of this reason. When you can look into the spine x-rays, you can see that it's hard to visualize the backbones. But when we use DEXA scan, we have got a better visualization of the backbones, and therefore we can pick the fractures, as you can see here. It's hard to visualize in a spinal x-ray, and therefore it's hard to pick up the backbone fractures, which are generally silent. And also radiation dose is quite high, and it's minimal with DEXA scanning. And it can be done when they're having their yearly bone density scans. So how do we prevent it? Well, continue mobility, continue exercise, because muscles keep, if the muscles keep working, they keep the bones stronger. Regular vitamin D supplementation. There are various ways of giving vitamin D supplementation. We found that our patients with Duchenne's muscular dystrophy like to take these medications once every 2 weeks. You can have daily injections, you can have weekly injections, or not injections, medications, oral, or you can have 2 weekly, whichever suits families. And always emphasize on taking adequate dairy products which are rich in calcium, which are important for bones. And good dental hygiene, just because if they need treatment, they need good dental hygiene. So what is the indication for treatment? It's if they have a long bone fracture or if they have a backbone fracture. So these are the two indications. And if they have this, then we start a medication known as zoledronic acid, which is given once every 6 months as an infusion. Each infusion lasts 30 minutes. First infusion does produce flu-like illness, so we do admit patients overnight, but subsequent infusions are given as day case unit. Timely induction of puberty is important because the hormones which are secreted during puberty increases bone strength, and that prevents osteoporosis. Now, we don't use this as preventive treatment, but there is some discussions ongoing. Should we give it as prophylactic? Should we start even before fractures occur? And there is opportunity for families with children with Duchenne's muscular dystrophy to contribute towards this discussion. And there's some leaflet which my colleagues have asked me to show it to you. Now, moving on to the emergency management, this would be mainly endocrine. It is very important that all families carry up-to-date documentation on the cardiac status, respiratory function, what to do if there is a fracture, and steroid management. I'll be discussing about steroid management, but it's always important to carry this documentation if you're going to see a doctor during emergency, during accident emergency trip, or if an ambulance comes to visit these patients. Now, what exactly is the endocrine problem with high-dose steroid? So high-dose steroids suppresses body's own production of steroids. So there is adrenal gland sitting on the top of the kidneys. It produces small amount of steroids. The problem, and also what it does is that during illness, it produces excess amount of steroid. Now, with high-dose steroids, which these patients get, there is shrinking of the adrenal gland, and therefore during illness, it's unable to produce excess steroids. And therefore, there is a steroid management plan which is given to each family. That is, those on daily steroid, they need to split the dose, half dose in the morning, half dose in the afternoon. The dose is good enough for emergency management, but it doesn't last for 24 hours, so therefore they're advised to split it into 2 doses. Those who are on 10 days off and on treatment, they need to take it every day during illness, and again split the dose. And those on deflazacort need they will require additional hydrocortisone for the duration of illness. And again, very important that you have a documentation of what to be what should be done for boys with Duchenne's muscular dystrophy when they're annual, and each child has an individualized plan, so we can't give one plan which fits everybody. And again, I've given a schedule here, but this is just what we do. and it can't be generalized, so please speak to your clinician if you want to get an individualized plan for your child. And again, there is this intramuscular hydrocortisone which is required if boys are if unwell and unable to take increased amount of hydrocortisone. If they are vomiting, if they are sick, then what we advise is to give intramuscular injection of hydrocortisone, but that would require immediate transfer to accident and emergency via ambulance. So you call ambulance and you give the injection. Documentation is very important, and this is an anonymized letter of my clinic letter, which gives a whole schedule of what to be done during illness. So this child is on deflazacort, and what is the sick day schedule on day 1, on day 2, and what should be done if unable to take this high doses of hydrocortisone, and what intramuscular injection should be. And sometimes they don't, most of the boys won't need to use this. And by the time we have trained them and by the time they have to use it, it's a while. So there is also a YouTube link for them to go and see how to administer these injections during illness. Now, just a word about this medication, which may be used in Duchenne's muscular dystrophy. It's a new steroid. It's got fewer side effects, but it doesn't rescue the adrenal problem. They still have adrenal gland suppression, and therefore extra doses of steroids will still be required. Just to summarize my talk, puberty delay is common. Almost all boys on steroids, so Duchenne muscular dystrophy, will have this problem. Most children will require kickstarting puberty with testosterone. Advice is definitely 14 years of age, but why not early if we know that it's going to be, the delay is going to be there, and if it helps in bone health. We do bone density scanning and look for the backbones once a year. Long bone or backbone fractures will require commencing bisphosphonate infusion, which is given once every 6 months. High-dose steroid suppresses adrenal glands, and it's important that each child has an individualized steroid plan of how to manage intercurrent illnesses with high doses of hydrocortisone, or if required, intramuscular hydrocortisone. Thank you very much, and happy to take any questions you may have.